Hello, dears, and welcome to Al-Hussaini Virtual Lab Pathology Talks, Tips, and Practical Tips. What I'm going to be sharing with you today is a nice example of endometrial endometrioid carcinoma, this time metastatic to the ovary. This is a case of a 54-year-old female patient who presented with abnormal vaginal bleeding. She underwent DNC followed by hysterectomy and bilateral salpingio-oophorectomy. And as in the case or tip presented number 108, this is somehow similar. I just wanted really to share with you the different example in which we would consider the ovarian metastatic rather than synchronous because of the invasion and dissemination of the tumor. So similar to that case, this is a scanning power magnification of the endomyometrium. And again, the tumor appears to be confined to the endometrium and just superficially invading into the myometrium. Most of the myometrium appears to be unremarkable with no evidence of involvement. So this is part of the endometrium, and then just the superficial part of the invasion, less than 50% definitely. And this is on higher power magnification. And again, this is a well-differentiated or a low-grade endometrial endometrioid carcinoma with the well-formed glands, and then we have the morules present and just superficially invading into the myometrium. And again, on high power magnification, just to appreciate that this was really a well-differentiated tumor, and the presence of the squamous differentiation and the morules would really support that this is an endometrioid carcinoma. Now, this is from the lower uterine segment, and as you can see, the lower uterine segment was extensively involved, and actually the invasion of the lower uterine segment was more than 50% of the thickness of the wall of the lower uterine segment. So the invasion was even more than what was really encountered in the endomyometrium, in the fundus where the tumor was present. And this is the cervix. And again, extensive involvement of the cervix, extensive stromal invasion, and the tumor was just barely few millimeters actually from the paracervical tissue, and on higher power magnification, the same appearance of the well-differentiated endometrioid tumor and the presence of the squamous differentiation. Now, importantly, and again, as an incidental finding that was not detected before surgery, this is the scanning power magnification of the ovary, of one of the ovaries, and then we have here the involvement by the tumor. So on high power magnification, the same tumor, exactly replica of what is encountered in the uterus. It is well differentiated or low-grade endometrioid carcinoma. And again, here on higher power magnification, showing the well-formed glands here and the squamoid areas. And again, here on even higher power magnification, just to appreciate that it has almost the same morphological appearance as is the tumor that was present in the endometrium and the cervix. Now, because the tumor extensively involved the cervix, we had to rule out to make sure that the tumor was an endometrial endometrioid rather than an adenocarcinoma arising from the cervix and then disseminating or involving the endometrium and the ovary. And the first stain that we would do is PR. PR is strongly diffusely positive. Remember that most adenocarcinomas of the cervix are completely negative. So this would serve as an excellent supportive marker for the diagnosis of endometrial endometrioid carcinoma. Vimentin, really very useful in this setting, and what you'll be looking for is what we call cup-shaped positivity. So we have the lateral walls as well as the base of the cell positive, while the luminal part of the cell is negative. This is the the typical positivity that we would encounter in endometrial endometrioid carcinoma environmental versus the endocervical carcinomas, adenocarcinomas, where it would be completely negative. Now, P16 is tricky because the squamous epithelium and the morule in endometrioid carcinoma tend to be strongly positive with P16, showing the nuclear and cytoplasmic positivity, similar to the block positivity that we look for. But this is only in the squamous epithelium and in the squamous morule. So if you look at the glandular component, it shows this mosaic pattern that would be in a way interpreted as negative staining. So just be careful with this pitfall, because P16 can be positive in the squamous epithelium and in the morules in endometrial endometrioid carcinoma. P53 was showed mosaic staining pattern. CEA, again, very helpful in this context. It's completely negative in a large part of the tumor. Now, there were other areas showing some focal positivity. This does not negate the diagnosis of endometrial endometrioid carcinoma. PMS2 and MSH6 were retained. If they were lost, they would be excellent supportive evidence for endometrial endometrioid carcinoma versus endocervical adenocarcinoma. But what we have from stains is excellent to support the diagnosis. So the final diagnosis in this case is endometrial endometrioid carcinoma. It's low grade, it's FIGO grade 1, involving the cervix and metastasizing to the ovary. This is extremely important because this is different from the Tip-111, in which what we consider the ovary is synchronous tumor involvement, like independent primary rather than metastasis, although we've mentioned that the most recent evidence suggests that these are clonally related. And the issue here, why did we consider the ovary to be metastasis? Because of involvement of the cervix and lower uterine segment extensively. And this would mean that the tumor has in a way spread from the endometrium to the lower uterine segment to the cervix and then to the ovary. Accordingly, the stage as per the FIGO staging system is a 3A1. This is opposite to the staging of the previous case, Tip-108, in which the stage was 1A3, complete opposite. So remember that in order to consider a tumor, endometrial tumor and ovarian tumor, to be synchronous, there should be no evidence of infiltration or invasion into other structures, including absence of involvement of the cervix. Remember, when there is extensive involvement of the cervix, you have to make sure that this is not a primary cervical carcinoma with secondary involvement to the endometrium. And still, Vimentin and CEA and PR are extremely helpful. Remember also that P16 can show this block positivity in the squamous epithelium as well as the squamous morules in endometrial endometrioid carcinoma, and this does not make it into positivity as is the case in endocervical adenocarcinoma. I hope you find this tip useful in your daily practice. Thank you.